Greetings. I am Dr. Karl Nath, the Editor-in-Chief of Mayo Clinic Proceedings, and I am pleased to welcome you to the multimedia summary for the journal's September 2021 issue. There are 3 articles that have been selected as our editor's choice or highlights articles this month. Our editor's choice this month is an original article entitled Identification of Genetic Causes of Focal Segmental Glomerulosclerosis Increases with Proper Patient Selection. It is authored by Dr. Jing Mayo and colleagues from Mayo Clinic in Rochester, Minnesota. Focal segmental glomerulosclerosis, commonly called FSGS, is the most common primary glomerulopathy in patients with end-stage kidney disease. FSGS is a histopathologic diagnosis for sclerosing lesions involving some glomeruli, focal, not diffuse, and only a segment of the glomerular tuft, segmental, not global. This seemingly straightforward histopathologic diagnosis noticeably belies the true nature, heterogeneity, complexity, and challenge of diseases complicated by FSGS. First, these lesions of FSGS are generally diagnosed by a 2-dimensional kidney biopsy section and not from 3-dimensional reconstructed images. When serial kidney sections are performed, glomeruli not involved in a given section may display segmental sclerosis in other sections. FSGS, in all likelihood, generally involves many more glomeruli than implied by the term focal. Second, even with regard to the seemingly monotonous histopathologic designation itself, there are variants of FSGS that are recognized, and these are described as either cellular, tip, perihilar, collapsing, or not otherwise specified lesions. However, these histologic variants do not distinguish between FSGS as is clinically categorized, namely primary, secondary, or genetic types of FSGS. Third, the pathogenetic processes that culminate in FSGS, their clinical presentation and features, and how they are therapeutically managed are quite varied. For example, primary FSGS is generally considered to arise from a circulating toxin that damages podocytes and the glomerular filtration barrier. FSGS is commonly attended by the nephrotic syndrome and is usually treated by immunosuppression. In primary FSGS, the nephrotic syndrome generally reflects a high degree of effacement of the foot processes of the podocytes, usually greater than 80% as assessed by electron microscopy. Segmental sclerosis likely involves all glomeruli at some stage in the evolution of primary FSGS. Secondary FSGS, on the other hand, does not usually cause the nephrotic syndrome and may arise from diverse conditions. These include obesity, reduced renal mass, sleep apnea, vesicoureteral reflux, drugs, viruses, sickle cell disease, among other conditions. However, there are some patients with presumed secondary FSGS in whom a known cause cannot be identified. More recently, FSGS is recognized as a consequence of genetic abnormalities that compromise podocytes and the integrity of the glomerular filtration barrier. Determining whether FSGS is primary, secondary, or genetic in origin is a key objective, as there are subtype-specific considerations with regard to prognosis, therapy, and transplantation. In the present issue of Mayo Clinic Proceedings, the study by Mayo et al. Addressed the utility of and the indications for genetic testing in patients with an FSGS lesion. Mayo classified patients with FSGS into 4 categories. Group 1 consisted of primary FSGS, namely the presence of nephrotic syndrome and greater than 80% of foot process effacement. Groups 2 and 3 consisted of secondary FSGS, namely the absence of nephrotic syndrome and less than 80% of foot process effacement, with or without an underlying cause. Group 4 consisted of undetermined FSGS, that is, patients in whom the degree of foot process effacement and the presence or absence of the nephrotic syndrome were not entirely consistent with the diagnosis of either primary or secondary FSGS. Remarkably, Mayo et al. Found a significant genetic abnormality in the majority of patients with undetermined FSGS and those with secondary FSGS without an underlying cause. Even in patients with secondary FSGS with an underlying cause, 33% of patients exhibited a genetic abnormality. The latter uncovered in the vast majority of patients in this group with a family history of kidney disease. Indeed, for the entire patient population, a family history of kidney disease was the strongest predictor for an underlying causative genetic abnormality. The study by Mayo et al. Is important and timely for numerous reasons. First, a monogenetic basis was found in over 40% of the total patient population, thereby underscoring the importance of genetics in driving nephropathies such as FSGS. Second, undetermined FSGS may indeed be determined by a genetic cause, a finding that raises the broader issue of the potential and power of genetics to elucidate other diseases generally considered idiopathic, cryptogenic, overlap, mixed, or undetermined. Third, this study clearly identified patient-specific features that portend an underlying genetic abnormality, and which should lead clinicians to undertake genetic testing in such patients with an FSGS lesion. Fourth, these findings show how concomitant genetic abnormalities may account for atypical features in FSGS, such as, for example, the failure of a patient with primary FSGS to respond to immunosuppressive therapy. Finally, genetic abnormalities may not only be the principal driver of FSGS, as occurs in genetic FSGS, but in other instances, they may provide a second hit, as occurs when a relevant genetic abnormality is detected in a patient with secondary FSGS who already exhibits a known predisposing clinical cause. Our first highlight this month is a review article entitled Rational Fluid Resuscitation and Sepsis for the Hospitalist, a narrative review. It is authored by Dr. Adam Ledzinski from Western Michigan University in Kalamazoo, Michigan, and colleagues from the Cleveland Clinic in Cleveland, Ohio. Hospitalists and generalists provide the first line of care to patients admitted with sepsis to medicine services, and the central management issues they face include those pertaining to fluid resuscitation, and when there's such resuscitation, need transfer to the intensive care unit and the addition of vasopressors. At the onset of their review, Ledzinski et al. Emphasized a number of key considerations, including the fact that while sepsis may cause both hypotension and shock, these complications are pathogenetically different. Hypotension represents a fall in systemic blood pressure below the autoregulatory capacity of major organs, but shock essentially reflects a compromise in tissue supply and availability and/or utilization of oxygen. Additionally, while sepsis may cause all major forms of shock, hypovolemic, distributive, cardiogenic, and obstructive, septic shock is generally hypovolemic and/or distributive in nature. The former results from true volume depletion alone or in conjunction with escape of fluid from the intravascular compartment because of cytokine-induced capillary leakiness. Distributive shock reflects venodilation with increased venous capacitance and attendant venous pooling. Both types of shock in sepsis reduce ventricular preload. Volume depletion is targeted by fluid resuscitation, while vasopressors reduce venous pooling. An additional consideration is that sepsis may lead to hypotension because of a reduction in arterial tone. The therapeutic implication of these considerations is that if fluid administration does not mitigate hypotension, especially when cardiac function should appropriately respond to increased preload, vasopressor therapy should be initiated to increase vascular tone and thereby treat hypotension and shock. Ledzinski et al. Reviewed the evolution of guidelines regarding fluid resuscitation leading up to the recommendations of the 2016 Surviving Sepsis Guidelines of a 30 ml per kilogram fluid bolus. These authors underscore the following points. First, fluid administration to achieve a normal central venous pressure, a CVP of 8 to 12 millimeters of mercury, as was done in the initial positive early goal-directed therapy trial, may be injudicious, as a CVP of 8 to 12 millimeters of mercury may be high in these settings. Second, fluid overload is associated with increased mortality because of multiple adverse effects of edema in various systems and organs. As regards which fluid to administer, the authors point out the lack of evidence supporting the use of colloids and that crystalloids are generally favored, with some studies supporting balanced crystalloids over 0.9% saline. Ledzinski et al. Review the resuscitation targets in sepsis, what these targets signify, their limitations, and how they may respond to fluid therapy, including such targets as systemic blood pressure, serum lactate, and capillary refill time. The subsequent section addresses the basis and importance of assessing fluid responsiveness, noting that besides fluid administration, preload may also be increased by a passive leg raise. An increase in cardiac output, an essential index by which to evaluate the efficacy of fluid administration, may be assessed by point-of-care ultrasonography or bedside echocardiography. The authors point out that fluid responsiveness may also be assessed by carotid Doppler, as carotid blood flow tends to track with that of cardiac output. They also point out the numerous challenges associated with collapsibility of the inferior vena cava in evaluating fluid responsiveness, and that measurements of CVP should play no role in assessing fluid responsiveness. In concluding, Ledzinski et al. Underscore the recognized adverse effects of fluid overload. They emphasize the need for hemodynamically grounded fluid administration. They caution against the administration of repetitive boluses of fluid, and they strongly advise transfer to the ICU and the use of vasopressor therapy when hypotension is refractory to targeted fluid resuscitation in sepsis. Our second highlight is an original article entitled Predicting One-Year Mortality on Admission Using the Mayo Cardiac Intensive Care Unit Admission Risk Score. It is authored by Dr. Thomas Breen and colleagues from Mayo Clinic in Rochester, Minnesota. In 2019, Jens et al. Introduced the Mayo Cardiac Intensive Care Unit Admission Risk Score for risk stratification of patients admitted to the Cardiac Intensive Care Unit, and they demonstrated that this model was superior to others, specifically the Sequential Organ Failure Assessment Score, or SOFA, and the Acute Physiology, Age, and Chronic Health Evaluation Score, or APACHE, in predicting in-hospital mortality. The Mayo Cardiac Intensive Care Unit Admission Risk Score, hereafter referred to as MCAS, is based on 7 elements assessed on admission: BUN, anion gap, the Braden skin score, the RBC distribution width, and the diagnosis of cardiac arrest, shock, or respiratory failure on admission. In the present study, Breen et al. Assessed MCAS in predicting one-year mortality by retrospectively reviewing CICU admissions from 2007 to 2018. In this patient population of over 12,000 patients, as MCAS increased, one-year survival decreased, with each of the 7 elements of the score significantly predicting one-year mortality. With an MCAS less than 3, the one-year survival among hospital survivors decreased as this score increased, with no further decline in one-year survival with a score of 3 or greater. Interestingly, 4 elements of MCAS associated with one-year mortality in patients who survived the initial hospitalization, and these included BUN, RBC distribution width, the Braden skin score, and respiratory failure. In discussing their findings, Breen et al. Make the following telling points, among others, regarding the attributes and greater reliability of MCAS vis-a-vis other risk models such as SOFA and Apache. First, MCAS is based on data at admission, not 24 hours of data, as utilized by these other scoring systems. Second, MCAS was obtained from a more recent CICU population and thus may more reliably disclose determinants of one-year prognosis. Third, SOFA and Apache were originally developed to assess in-hospital mortality and are primarily based on indices that reflect acute illness. In contrast, MCAS incorporate markers of both acute and chronic illness. This latter consideration is especially germane, as in the study by Breen et al., markers that correlated with one-year mortality were those that reflected chronic illness and frailty. This study is an important contribution because it complements prior findings demonstrating the validity of MCAS in predicting mortality during hospitalization for an acute cardiac illness. Moreover, this study underscores the importance of frailty and chronic comorbidities as determinants of more distant outcomes following acute admission to the CICU. Finally, this study validates MCAS as a reliable risk stratification model in predicting one-year mortality when managing, decision-making, and prognosticating on acutely ill patients admitted to the CICU. You can access these highlights and editor's choice articles free of charge during the entire month of September. When you visit our Mayo Clinic Proceedings website at www.mayoclinicproceedings.org, you will find links to our social media by clicking the buttons at the top of the homepage and at the bottom of any page to follow us on Facebook, Twitter, and YouTube. On our YouTube channel, you'll find full-length author interviews called Insights, 60 seconds video article synopses, and our Mayo Clinic Proceedings issue summary and author insight podcast recordings, which are available from our website on the homepage as well as through iTunes. You'll also find our online-only feature, Pioneers and Legends in Medicine, which are video interviews of people who've made a strong impact in their field of study. You will see many news stories on our website that are based on articles published in Mayo Clinic Proceedings. And finally, you will see other free content, such as our Path to Patient image quiz, medical images, stamp vignettes on medical science, and art at Mayo Clinic features, as well as articles published online ahead of print. As always, we greatly thank you for your interest in and your support of Mayo Clinic Proceedings. We hope you found this presentation from the content of our website valuable. Our journal's mission is to promote the best interests of patients by advancing the knowledge and professionalism of the physician community. If you are interested in more information about us, our homepage is www.mayoclinicproceedings.org. There you'll find access to information for our social media content, such as additional videos on our YouTube channel or journal updates
on Facebook. You can also follow us on Twitter. More information about healthcare at Mayo Clinic is available at www.mayoclinic.org. This video content is copyrighted by Mayo Foundation for Medical Education and Research.